نعم عمي.
Shall we start?
عمي بعد 1 minute. الساعة 8 نبدي دقيقة.
دقيقة اوكي.
عمي عبد الواحد موجود؟ ما ادري وين اختفى. ليش دوامكم عمي سالم؟
8 to 5.
8 to 5 اوكي. ورجعتوا تو فول كاباسيتي حاليا مورنينج بدون شفتات.
Everybody is coming to work. We don't have two teams. We are back to normal now.
يوم بالله. عمي عبد الواحد can you start؟
الكلمة عند دكتور سالم. He should give the green light. If you want to wait another 1 minute, because the people will come. I'm sure now it will reach 50 in 2 minutes or 5 minutes.
Okay, I think we should just start on time.
Yeah.
خل اسوي introduction للدكتور سالم من الجروب مالته. اوكي دكتور سالم.
Okay, so here I have Dr. Bala Morgan. He's a consultant radiologist at SSMC, and he will be talking about abdominal CT for trauma patient. His second presentation will be damage control surgery, and that will be given by Dr. Jamie Fitch. She is a consultant in general surgery, acute care, and trauma surgery as well at SSMC. Third presentation will be radiology again, and it's Dr. Shahbaz Batil. He's a consultant intervention radiologist at SSMC, and he will be talking about the intervention radiologist role in the management of blunt abdominal trauma. The last presentation will be from Dr. Ahmed Al-Sayali, who is a consultant general surgeon, acute care surgery and trauma at SSMC. And he had a case presentation. It will be an epigastric stab wound and what's the management presentation and management of the case. So I think it's time to start with Dr. Bala. Dr. Bala will talk about the management.
You can still just 1 minute to introduce everyone to you.
Okay.
First of all, thank you everyone for attending our regular Al-Qasmi meeting. This week we are delighted to have Dr. Salam and his group from Sheikh Shakhbout Medical City. Dr. Salam is a consultant general on biliary surgery. He's the acting head of department. He and his group lead a level 1 trauma center in Al Hospital. Now they are in Shakhbout Medical City. So we're very eager to learn from their experience regarding the management of abdominal trauma. Hopefully, we have more and more meeting with you, Dr. Salim.
Sure,
So,
anytime.
If we can start, it's all yours.
Thank you. So Dr. Bala will present on the role of CT scan, abdominal blunt abdominal trauma. And just start the presentation for Dr. Bala. Can you see the screen now?
Yeah, I mean we can see, yes.
Okay. Okay.
Good evening. I'm Dr. Bala. I'm one of the radiologists working currently at SSMC, but I've been working in Abu Dhabi, joined Mafraq 6 years ago. Thank you for the opportunity, and I hope everybody can hear me well. We'll go straight into the presentation.
To the mic, Dr. Bala.
Sorry, come again.
If you can come closer to the mic.
Yeah, sure. I'll bring it. Okay, how's it now?
Yeah, can you hear us?
Yeah, fantastic.
Okay. So mainly, we are going to talk about the pitfalls and pearls in blunt abdominal trauma. So that's our presentation. We are not going to talk full detail, just the pearls and pitfalls. What is the role of imaging in blunt? So as you all know, the surgeons do a primary, secondary, and a tertiary survey. That is clinical, and radiology is going that way, primary, secondary, and tertiary. And that's how the report will be in the future. So you need to understand the basic mechanism of the injury for me to report the CT scan. And what is the role of imaging in blunt trauma? So the mechanism, you need to understand three types of mechanism in blunt abdominal trauma. One is a rapid deceleration that causes tears at the fixed points. Usually the DJ flexion, the left upper quadrant to the root, the mesentery at the right SI joint. That's the two fixed points in abdomen. And the second is the crushing injury. Massive force crushes the contents between abdominal wall and the spine. And the third one is the extreme external compression, increases the pressure in the abdomen that causes hollow viscous perforation. These are the three main things. We all know the commonly injured organs: spleen, liver, kidney, small bowel, bladder, colon, diaphragm, pancreas, and major vessels. We are not going to discuss individual organs here. We are not going to discuss the grading of AAST or the individual types of injury. So AAST grading, everybody needs to understand there are three types of grading. We always get mixed this up. One is radiological or imaging grading. The second one is a surgical or operative grading. And the third one is a pathological grading. So we should not mix and match. There are three different criteria when you say AAST grading. That's all I'm going to talk about AAST grading. It's all available in the internet if anybody wants to look at the grades. So it's usually a multimodality approach. Traditionally, chest X-ray, pelvis, and cervical spine used to be the traditional. We moved on to do ultrasound, fast scan. That's mainly for the clinicians. The radiologists have moved away from that. Diagnostic peritoneal lavage, it's a thing in the past. It's usually done nowadays, maybe in the military war field, no longer in the hospital practice. And CT scan is the main choice. So two types of scan. One is a pan scan, which is a whole body scan, versus selective scan. When we talk in this presentation, we are talking mainly level 1 trauma, what we call in our hospital, or you can call it as a severely injured patient. And this is mainly a blunt abdominal trauma. We are not talking about penetrating trauma. And what do we do? The CT scan is arterial phase from the neck, skull base, up to the groin, well below the groin, the whole single shot, and then followed by a portal venous abdominal pelvis. Why CT scan? The main thing in the CT scan is to differentiate first is two things. One is active bleeding, and the second one is pseudoaneurysm versus AV fistula. What is the definition of active bleeding? It is actually you're opening the tap. You contrast extravasate gets bigger on the delayed imaging. And the Hounsfield unit, which is the CT unit that matches the intravascular contrast. What I mean, I will show you the picture and explain. Pseudoaneurysm is a difficult one to diagnose if you don't do at least dual phase. You have to do minimum 2 phase. That's why then only you can pick up the pseudoaneurysm. Why do we need to know this? This can decide who goes to theater, who goes to observation room, or who goes to IR, which is the interventional radiology. Get the scan correct. So this is the publications. So you have to do minimum 2 phase. There is no doubt about that. And we do arterial phase, which is approximately 25 to 30 seconds from the time of the injection from skull base to upper thigh. Portal venous, which is 65 to 75 seconds delay from the time of the injection, abdomen and pelvis. No need to give oral contrast. We don't need oral contrast. We are not talking about penetrating trauma. We are talking about blunt trauma. This is the most recent publication in 2016. The time spent by each patient in the scanner room should be less than 10 minutes. If you are getting it wrong, meaning that the setup is not correct. It is not the scan that is fault, the setup is fault. So this is just a statistics what happened in MAFRAC before. So usually you get between 150 to 200 cases per month. And the age is between 20 to 50. So which is matches the world epidemiology. And the two types of mechanism we see here, one is fall from height. The second one is the MVC. So it again matches the epidemiology throughout the world. So what are all the questions you need to know? First question is the technique of the scan correct? Is there evidence of bleeding? If there is bleeding, is it an active bleeding or a pseudoaneurysm bleeding? And the fourth question is the bowel and mesenteric injury? And the fifth is, are there signs of hypotensive complex? I will touch on that. And then you know the solid organ, the pattern of the injury, and then the survey, primary, secondary, tertiary. So we move on to cases. Why do we need two phase? This is this case that you can see here, that's the arterial phase. You can see contrast only in the aorta and the cortex of the kidney, meaning that arterial phase. You can see a pool of contrast. Then you go on to the portal venous, it becomes iso to the parent organ. That's a pseudoaneurysm. Okay. And then you go on to angio, you embolize it. That's a pseudoaneurysm. This patient can be managed without going to OR. This is another case. Again, this is a tiny blush there in the arterial phase, gets bigger, but iso. It is not matching the aortic. So that's again another pseudoaneurysm. Okay, that's been managed by IR. I'm not going to dwell too much on this because my colleague will touch on this. This is what more important is. You can classify this as a very small liver laceration in segment 6, the inferior aspect of the liver, with a tiny blush of contrast in the arterial phase. And if you look outside, there's a small amount of hemoperitoneum just below the liver. And that's a pseudoaneurysm. If you grade it, just by the size criteria, it's grade 2. But if you have an active extravasation, it becomes grade 3 to grade 4. But the point I'm trying to make here is, this is our role. This is what we need to pick it up. Is there an active bleeding? Yes. Go on to IR. You go on to IR, that's a site of bleeding, embolized, patient managed, non-operative. So this is an example of active extravasation of contrast. This is aortic phase, contrast in the aorta. You can see that is a hematoma there. The contrast is getting there, and the contrast is getting bigger on the late phase, outside the spleen as well. That is active bleeding. That's clinical management and the clinical decision. Whether the patient is fit to go to OR, then we should go to OR. Again, active bleeding, arterial phase, you can see a small blush. Okay. This is not active bleeding. This is a rounded pool of contrast that becomes iso with, if you compare the contrast density with the liver, it matches the same, meaning that that's a pseudoaneurysm. That's again can be managed by IR. I'm not going to dwell on this one. Okay, we'll go there. This is the major publication saying that you need minimum 2 phase, arterial phase and portal venous phase. It's been well studied with no doubt, minimum 2 phase. Whether we need a delayed scan for urographic, urine leak, that depends upon the clinical situation of the patient. If the patient is stable enough to wait for that minutes, then you carry on. If the patient is not stable, you cannot hold the patient in the CT room. Okay, now we go on to the main business. So this is the bowel and the mesentery. So I'm showing you just a single shot images that we used to get problems with the video clipping. That's why I'm showing you single shot images. You have to take my point that the solid organs in this coronal plane is normal. You have a hemoperitoneum in the right iliac fossa. That's the axial section. That's a pool of contrast bigger than the parent vessel, implying active bleeding in the mesentery with the hemoperitoneum. If we concentrate on the bowel here, this is a collapsed bowel. This is a dilated bowel. And the enhancement of this bowel is less. Again, coronal plane on the portal venous phase, hemoperitoneum. If you look at this bowel is less enhancing, dilated compared to the rest of the bowel, meaning that that bowel is crying for help. You have active bleeding in the mesentery, you have hemoperitoneum, that bowel is dilated. Again, the 2 areas of mesentery that gets injured is the one that often flaps around, which is a sigmoid mesocolon, and the another one is a transverse mesocolon. So this is a sigmoid mesocolon, stranding here, which is a thick wall bowel, stranding, which is sigmoid mesocolon injury. We leave the rest with the surgeon, whether they wait or they go in. This is just another plane showing sigmoid mesocolon stranding and hematoma. There is no extraluminal gas, no pneumoperitoneum, but this is a concern area for us to alert the surgeon that they need to assess clinically. And seatbelt sign very often don't get mentioned in the request, which is very important for us. And sometimes we see it on the CT scan. This is a seatbelt sign. And when you see a seatbelt sign, then you are worried. You know the 2 fixed points, the DJ flexure and the right SI joint. Then you look at the abdomen and the right iliac fossa. You can see the stranding, hematoma, hemoperitoneum, dilated bowel. And then again, that's a tiny bubble of gas outside the bowel wall with dilated bowel, small bowel feces. Why would a young patient who was otherwise working as a scaffolder or a laborer, he should not have small bowel feces in the setting of blunt trauma with mesenteric stranding and mesenteric hematoma. So this is another patient. You have a little bit of ascites around the liver, but solid organs are normal. Okay. Again, this is a transverse mesocolon hematoma. So this is my favorite topic, tiny bubbles, big troubles. What do you mean by that? Okay, this is blunt abdominal trauma. You can see a tiny bubble of free gas. That is just the tiny dot, but that's enough. That is the hard sign in radiology, unequivocal. Nobody can raise a doubt in a blunt abdominal trauma. That is a perforated hollow viscous. And that's the case there. This is a jejunal perforation. This is another case, tiny bubble of gas around the spleen in a blunt abdominal trauma in an otherwise fit and well patient previously. That is a hollow viscous perforation. This is a patient who landed in his gluteus, fall from height, who have gas in the ischio-anal canal with no penetrating injury, meaning that that integrity of the anal rectal sphincter should be questioned big time. Then that patient needs anesthetic and general anesthesia, UEA, clinical examination by a surgeon to assess the anorectal sphincter. So difficult areas in CT scan. I have to accept this is still a difficult area. Again, we are talking about blunt abdominal trauma. This is a patient who was involved in a blunt abdominal trauma. You can see a gas anterolateral to the duodenum, laceration through the pancreas. That's enough. That is a major pancreatico-duodenal complex injury. That's the way I diagnose it. I can't go into fine detail. Most of the surgeons, that's enough. If they have gas outside the duodenum, the pancreatic head is transected, meaning that that is a major significant injury of a very complex anatomical location. So this is the coronal plane of the same patient. You can see that there's a gas outside the duodenum. Okay, this is full of hematoma. The same patient has got liver laceration. The problem with the blunt abdominal trauma is when you see such complex injuries inside the abdomen, they always have a liver laceration, splenic laceration, renal laceration. So we should not get satisfied finding this diagnosis, but what makes a big difference is the hollow viscous perforation, pancreatic injury, mesenteric injury. Okay, the same patient has got renal laceration. This renal laceration. This patient was managed as a damage control surgery and was discharged 3 weeks later. Okay, we'll move on quickly. It's a matter of time. Okay. This is just to say what is the sensitivity and specificity by radiology in picking up bowel injury. If you look at the 2 column, it is almost like you have to cross match, not directly, the opposite direction. The higher the specificity is the bowel wall discontinuity. But unfortunately, the sensitivity is only 5 to 10%. Okay. Ascites is highly sensitive, but the specificity is very low. Okay. So you have to go and find these things and match and present the case back to the surgeon after looking at the CT scan. Okay, this is a patient who has massive liver laceration, fluid in the liver, around the liver, and then you have pancreatic injury. That's a straightforward case. But if you look at that, 90% of the time, for some reason, the right lobe of the liver is involved in laceration. When you see a hint of left lobe of the liver laceration, it is telling you the impact is in the midline. Then you move your concentration to the pancreas. This is another patient, fluid around the liver. You have left lobe liver laceration, meaning that you have to concentrate more than the liver. Then you look down, next slice here, you have fluid between the splenic vein and the pancreas. That is one of the hard signs for implying pancreatic injury. And if you look at the pancreas, that's gone. So what I'm trying to say here is when the patient gets pancreatic injury, it's very easy to go back, retrospectively diagnose it. But on the spot, at the time of the scanning, it's difficult because people get distracted by liver laceration, splenic laceration, renal laceration. So that's why you need to know the site of impact. The impact tells you exactly where to look for. Often pancreatic injury, I'm sure many people have the same experience, is overlooked. This is also in our practice. So this patient had fluid around the stomach, splenic laceration. This was not picked up on day 1, the pancreatic injury. This is on day 2, very obvious, very clear. That's picked up, then it was dealt with. The favorite question asked by a surgeon, can we repeat the scan to assess for extraluminal air in suspected bowel injury? What is the time frame? I have no answer to this. Maybe minutes, maybe hours, or maybe days. The problem is it's very easy if the patient is conscious, alert, oriented. They can follow clinically with no doubt. But if the patient is intubated, ventilated, for whatever the other injuries are, such as head injury or spinal injury, then it becomes very tricky. I will show you a case. This is a scan from my neighboring hospital, Rahaba Hospital, transferred us. This is the arterial phase. You don't see any free gas in the arterial phase. Within seconds, you can see a free gas. This is a portal venous, this is arterial. Within seconds, the gas is appearing. So how can we prescribe that this is a time frame that you have to follow the scan? That's why the difficult area is. So this is another case. Again, this is one of the lessons I learned in my life. So this is a significant renal laceration, renal hematoma, free fluid below the liver laceration, very excited, and then gas in the right iliac fossa, anterolateral to the cecum. That's it. We thought our job is done. So we have identified liver laceration, kidney laceration, perforated hollow viscous. Patient went on to have an ileocecal resection and was discharged in day 7. Came back 2 weeks later on with abdominal pain and increasing ascites. So because it's a postoperative scan, we give oral contrast to know the integrity of this anastomosis, to identify the ascites is not due to bowel leak. There was no bowel leak, but luckily the radiologist waited for 10 minutes, and then identified the contrast was coming out of the renal collecting system. So we missed the renal collecting system injury, despite diagnosing liver, kidney, and bowel. So isolated bowel injury is only 3 to 5%. The incidence of bowel injury reaches up to 34% when there are more than 3 organs injured in a blunt abdominal trauma. This is from the Emergency Trauma Journal. Skip that. Okay, this is one thing that I need to concentrate here, very often not described in many conferences, but this is a reason that we radiologists get stuck while we're reading the scan. There are several signs of hypotension complex that's been described over a period of almost 12 years now. So what are the signs of hypotension is collapsed IVC, small aorta. You can have abnormal enhancement, unthickening of the bowel, abnormal enhancement of the pancreas with the fluid around the pancreas, and a hyper-enhancing adrenals. Okay, this is a case you can see here. I'm sorry, I'm struggling with this. Okay, this is the IVC. That's flat IVC, meaning that this patient is in hypotension. This is another patient, flat IVC with a small aorta. Hypotension, large retroperitoneal hematoma on the left side. Okay, this is another patient. You have flat IVC, hyper-enhancing adrenals. Again, hypotension complex. Okay, this is another patient with the liver laceration with a flat IVC, hypotension complex. This is another patient, actually his abdomen was okay, but he was in spinal shock. That can also cause apparently the hypotension complex, which fluid around the pancreas. This is a hyper-enhancing bowel that has got nothing to do with the bowel because the patient is clinically fine, but it is also a sign of hypotension complex. So why do we need to talk about it? Because we are dealing with young patients who are often the breadwinners of the family. So they are working outside. They are not like sick people with comorbid illness. They usually people who are involved in trauma are otherwise fit. So when they have compensated, the imaging signs appear before the clinical signs. You can have a little thin aorta or a thin IVC or hyper-enhancing adrenals, which is apparently in young people manifests in CT scan before clinical signs, and then decompensated, meaning that the clinical signs develops. And then the third group is irreversible. What do you mean by that is this third group is up to 70% mortality, which means the kidneys don't enhance. Okay, you have a hollow sign, low attenuation around IVC, meaning that it is too late to reverse the hypotension complex. With my experience is often you see this group of hypotension complex variants in patients who are on inotropes. So I'm sure there will be more publications coming out. The CT imaging does not match the clinical course because we don't know the patient was on inotropes. That's the future to look for. Ascites. This is my last slide. So basically, ascites is not a diagnosis. It is a finding. And never get satisfied with ascites. Just ascites, that's it. It's not a diagnosis, it's just a finding. You have to have a systematic approach, and we learned from our lessons. This is a patient who had previous bariatric surgery, bypass, came with the blunt abdominal trauma, hematoma around the region medial to the gallbladder with a little bit of ascites. Patient was reluctant for laparoscopy, diagnostic laparoscopy. So we monitored him. If you look at the date here, it was 14th of the 9th, 2017. And all these scans I showed you are from MAFRAC. And this is the same, after 12 hours, we repeated the scan and the ascites is increasing. So when you put together hematoma around the gallbladder with increasing ascites, meaning that the integrity of the biliary system is questioned. Then the surgeon went in, it was a perforated gallbladder. Okay. This is the follow-up scan with oral contrast because of the bariatric surgery. But there was no problem with the oral contrast, but there is a hematoma increasing, ascites, gallbladder collapsing. This is another patient who had ascites. This gas is extraperitoneal. This is not intraperitoneal, that's outside the peritoneum. You have ascites here, you have ascites here, solid organs normal, but what is you're seeing here, a significant pelvic fracture on the right side. So when you see ascites like that, even though the bladder outline looks normal, do not stop, please. Do not stop, because you don't know, you haven't found the cause of the ascites. You just wait 7 minutes, minimum 7 minutes. We didn't do anything else. We waited 7 minutes. The contrast was coming out of the bladder. What we thought is an ascites is an urine. Okay. So that is need to go to theater. So the pitfall. What is the pitfall? What do you do with young female? Okay. Often we all know we are doing ultrasounds more and more in all abdominal pain, and we are seeing more and more ascites nowadays. Very small ascites, Hounsfield unit in the CT should be 10 to 15. Okay. It may be physiological in young female, and increasingly we are finding it in young male patients as well. And then it was published in radiology. I don't know about surgical publication, but it was published in journals of radiology way back in 2008. And what they found, they followed these people before and after the CT scan. Apparently what they're saying is they have received excess IV fluid resuscitation, and that's what they can explain the ascites. But can we close the book in a male patient who has got ascites? No, you should be exhausted finding the cause of the ascites. Make sure it is not urine, make sure it is not bile. So, pitfalls is the gallbladder, pancreas, duodenal injuries is always going to be difficult areas to diagnose unless we look for it. We can only look for it with the help of the surgeon who says he is not happy with the abdomen, the impact is in the epigastrium, there is bruise in the abdominal wall, mainly in the epigastric, there is seatbelt sign. Then you go back and look at the scan. Pelvic fractures, do not give up, do not overlook the bladder looks normal, the kidney looks normal, doesn't matter. If you have a major pelvic fracture with hematuria, you must assess the renal tract. With and without hematuria, you have to take what you find on the scan. For example, if you have an ascites, then you must make sure it is not urine leak. And there are only two factors. One is technical. Do we get the contrast steady correct? Or we are our timing correct? The second thing is the patient factor, which I told you earlier on, that hypotension complex makes us more confusing. Are we looking at hypotension complex, or are we looking at more significant injuries? Penetrating injury, I'm not going to talk. That's almost there. Summary, the whole body scan will keep increasing in the future, no matter we talk about it. The teamwork will only work if you have an effective leader. And this is the third thing we teach our residents, that avoid satisfaction of search in severely injured patients. And the final bullet point is, imaging is not a substitute for clinical examination, but I'm afraid that's the way the world is going nowadays. They want to do a scan, normal, discharge. That is not a substitute. Getting it right is not an issue now, but we are overdoing it. And there is a publication last year in our biggest radiology journal in May 28, 2019. After, I'm sure they must have thought about it before publishing it. There is no benefit after high energy impact with a normal physical and a normal clinical examination. There is no benefit of whole body CT scan. This was published last year. I'm sure the world will start questioning this. And thank you.
Okay, thank you, Dr. Bala. Great presentation. So just for the interest of time, just ask two questions. Bala, one question is, do you use rectal contrast if you suspect rectal injury?
In blunt abdominal trauma, you usually no, unless the surgeon comes back as to say that they have examined clinically, not under the anesthesia, they have examined clinically, they are not sure. Then I have to prove or disprove by putting rectal contrast. Usually in blunt abdominal trauma, my experience is there is always secondary signs. If you have a mesorectal fat standing, if you have a mesorectal fluid, if you have mesorectal gas, that is enough to say the integrity of the rectum is no longer 100% clear. If you want us to prove, we can do rectal contrast, but I don't think, in my experience, I have done that unless it's a penetrating injury, there is an open perineum, there's an open fracture with pelvis falling apart, then you have to put a contrast in, because the gas could come from outside.
All right, the last question is, can a CT scan prove or exclude compartment syndrome in the setting of trauma?
My experience is no. No, we can include, we cannot exclude, because your intra-abdominal pressure, we cannot match that. As I told you, the hypotension complex in this group of people confuses us a lot. And that's why we tend to overestimate or underestimate. We can say there is a suggestion of compartment syndrome, but we cannot say there isn't, because that is purely clinical.
Okay, thank you, Dr. Bala. So I think it's time to move to the second presentation. The second topic is very important to all of us. It's the damage control surgery. And Dr. Jamie Fitch is a consultant in general surgery, trauma and acute care surgery, and surgical ICU. And she will be talking about damage control, which is a very important principle in surgery as a whole, not only trauma. Jamie, you can start sharing your slides.
Thank you, Dr. Solomon, and thank you, Dr. Bala. That was a great review of some of the imaging findings. I'll start with, I'm going to discuss the damage control approach to the unstable trauma patient. I think it's important to note that a lot of the CT findings that Dr. Bala just showed us, in these patients that you're taking a damage control approach to, you should never see those CT findings because the unstable trauma patient in general does not belong in the CT scanner. And so I think, while it's not the focus of this talk, it is important to remember the importance, as Dr. Bala mentioned, of physical exam and physiologic measurements to determine which patients actually are stable enough to undergo imaging and which patients just belong in the operating theater for a more damage control approach. here. When we're discussing abdominal trauma, I think it's important to note in 2012, a study of the National Trauma Database reported that 14.8% of all trauma patients actually sustain an intra-abdominal injury. And so a high level of suspicion for these injuries is crucial to make sure that you don't miss an injury and discharge a potentially unstable patient. Solid organ injuries most often result in hemorrhage. Hollow viscous injuries obviously can be a combination of both hemorrhage and intra-abdominal contamination or infection. And the priority in these patients has to be resuscitation, followed by immediate or rapid identification of injury, control of bleeding, and control of contamination. So what is damage control? The concepts of damage control were actually first described in the 1970s in the context of major hepatic injury, as surgeons became more and more aware that rapidly controlling hemorrhage and getting out of the operating theater led to improvements in improvements in survival for patients with major liver injuries, and that trying to get a definitive, complete, and even pretty repair at the beginning can actually prove fatal for the patient. The term damage control was first used in 1993 in a publication by Rotondo and his partners. And it was a reference actually to US Navy terminology. When you find yourself on a sinking ship, plug the hole. You don't have to actually repair the ship formally. You just need to stop the water from coming in so that the ship doesn't sink. And I think that's the concept that's most important in this unstable trauma patient who's bleeding and in shock, that the first priority has to be to get out of the operating room and to the ICU where you can get the patient warm. And we'll talk about why those things are so important. Damage control is described in 5 different stages, which I've listed here. It's identifying the patient who is in shock, so you know which patients you can take more time in the theater to do definitive repairs and which patients you need to take a damage control response to. Secondly, the abbreviated surgery or control of hemorrhage and contamination. Third, dynamic reassessment within the operating theater so that you can change your plan as you go depending on the patient's condition and the injuries that you found. Followed by optimization in the ICU, and ultimately return to the operating theater for your definitive repair and reconstruction after the patient is more stable. So it's important to be able to identify which patients are in shock. To do that, you need to know what shock is, which is just a syndrome of inadequate tissue perfusion. I think it's important to note that a damage control approach, while we most frequently discuss it in the context of trauma patients who come in unstable, it's also used, and I think has been used at SSMC more frequently in the last several weeks in an emergency general surgery scenario than it has actually in trauma. And so the patient with a devastating intra-abdominal disaster, or even the patient with an intraoperative injury or misstep, vascular injuries, and unexpected bleeding in the context of even a planned operation may need to revert to a damage control approach if the patient is becoming unstable in the OT. Signs of shock, which we all know: hypotension that's uncontrolled, tachycardia not responding to resuscitation, tachypnea, oliguria, even cutaneous hypoperfusion and pallor may be a sign of shock. Hypoxia and mental abnormalities or depressed mental status are all evidence of shock, as is a metabolic acidosis with a low bicarb, high base deficit, or a pH less than 7.3. These are things that need to be recognized and rapidly corrected if possible in the process of getting to the operating theater. So when we talk about damage control surgery, the first thing to talk about is the approach to the trauma patient with an intra-abdominal injury who's unstable. It is most commonly an exploratory laparotomy with a generous midline incision from the xiphoid all the way to the pubic tubercle. There's no room for small incisions or limiting scarring in these patients. I always say big problems deserve big incisions because you can respond most quickly through a big incision. Immediately pack all 4 quadrants, regardless of where you think the bleeding is from. Again, most of these patients haven't actually made it to the CT scanner, so you get to the operating theater and you don't know what injuries you're actually looking for and which area to start with. So always start by packing all 4 quadrants. That means over and under the liver, over and under the spleen, and in the pelvis. Once you have all 4 quadrants completely packed, most injuries will be controlled with packing. As far as the blood loss. And so that gives you time to actually stop and let your anesthesiologist catch up on resuscitation so that the patient who is unstable, hypotensive, you may be able to get them caught up to a more normal blood pressure just with the process of packing and stopping And I find this to be one of the most challenging parts of the operation, actually, is having the discipline and the patience as the surgeon to just stand there and cross your arms and not move, and not go diving into the injury while you let the colleagues on the other side of the curtain actually catch up with resuscitation. Once you have some catch up, you have time to start systematically unpacking and finding those actual injuries. The concept of damage control requires a recognition that definitive repairs of injuries takes time. And as surgeons, I think most of us find it difficult to recognize just how long it takes us to do things that we do in the OT. And so remembering that everything you do takes longer than you think it's going to. As a surgeon, my estimated time for my operation is almost always short of what it actually takes me. So recognizing that and finding the quickest ways to get in and out of the OT can be life-saving for the patient. Long operations will lead to more and more progressive derangements in physiology as the patient becomes more hypothermic, more coagulopathic. There is good data that's been proven over and over and over that the more hypothermic a patient gets, the more the coagulation cascade is interfered with, and you're going to get more and more coagulopathic bleeding. So recognizing the difference between surgical bleeding that you can control with stitches and staples and the coagulopathic bleeding that will appear as just a diffuse ooze from every surface that you see, and recognizing that you can't stop that coagulopathic bleeding with more sutures. And so the goals of a damage control operation become, number one, control of surgical bleeding, because bleeding kills patients fast. That can happen with just packing. That can happen with ligation of blood vessels, or even division of structures. Secondly, control of contamination, because contamination uncontrolled will kill a patient very reliably, if not as quickly as bleeding. Which means resecting the portion of the bowel that's injured, or even sometimes just oversewing or clamping that portion of the bowel, but not necessarily a definitive repair, and anastomosis. The danger in that anastomosis, I think, is twofold in a damage control scenario. Number one, creating anastomoses and putting the bowel back into continuity takes time, which the patient doesn't have. The longer you're open on the table, the more fluid you're losing, the more heat the patient is losing. Up to 1 liter of crystalloid is lost every hour that the patient is open with a midline laparotomy. And so you can divide and resect a segment of bowel in minutes, and then spend an hour and a half doing a hand-sewn end-to-end anastomosis, and you end up with a dead patient with pretty bowel. The second pitfall of that anastomosis that's done unnecessarily is that this is a patient who's unstable, is going to require ongoing resuscitation, and that anastomosis is going to swell, and has a very high risk of breaking down and leaking, which makes the patient just sicker later. Third, controlled resuscitation within surgery. So I think oftentimes what the anesthesiologist is doing at the head of the bed is at least as important as what I'm doing as the surgeon in the abdomen, sometimes even more so. So direct communication with your anesthesia colleagues to make sure that they are giving an aggressive but controlled resuscitation, that they're giving blood products and not significant crystalloid, and that they are letting you know what is changing in your patient's hemodynamics the whole time you're operating. I find that maintenance of that teamwork approach and that discussion from one side of the bed to the other can be the most important part of the operation. And finally, what is described for most of these patients is actually a temporary abdominal closure for several reasons. One, a temporary abdominal closure, and we'll talk about how you can do that, leaves room for the bowel to swell and decreases your risk of developing an abdominal compartment syndrome later in the ICU. It's not impossible with an open abdomen, but it is less likely. And also definitively closing the abdomen takes time, which again, these patients just don't have. So I'll go through very quickly. The goal of this talk is not to tell you specifically what operations to do for every organ injury, just to touch on some of the overarching concepts. I think when we talk about the spleen is the most commonly injured organ in a blunt mechanism, and that's because it's just fragile. It's important to remember that you can live without the spleen. Most people don't want to, and most splenic injuries can be managed without splenectomy, but in my mind, splenic salvage has really no role in a damage control scenario. If the patient is hemodynamically unstable, the spleen should go in a bucket and it should go there within minutes. The liver is the most commonly injured organ in a penetrating mechanism, up to 22%. and that's just because of its size, and there's so much of the abdomen covered by the liver, and so it's easy for it to get hit. It is also a very vascular structure, obviously, and you can't live without it. And so I cannot, while unlike the spleen that I can just rapidly remove to stop the bleeding, I cannot do that with the liver. But it is important to remember that most liver injuries can actually be controlled with just packing. And if you have the discipline to pack the liver appropriately and to leave it alone and stop touching it, most of your liver injuries you can actually manage with just packing, and the bleeding will stop. There are several published algorithms for managing liver trauma. And again, the specific details of those are beyond the scope of this, this talk. The important thing to remember is that your goal here is to control hemorrhage and not necessarily to make it look pretty. So if I can control hemorrhage with a couple of big blunt sutures in the liver, if I can control that hemorrhage by just packing and leaving it alone, that's a whole lot faster than trying to definitively staple off and do an anatomic resection of the liver, which takes a lot of time and is associated with creating more and more just raw surface of the liver that will bleed on its own. Abdominal great vessel injuries are something that every surgeon sort of lives in fear of, I think, because it can be difficult to get there quickly. And so going through in your head and practicing these maneuvers to be able to expose the IVC on the right with the Cattell-Brash maneuver, which requires mobilizing the right colon up off of the peritoneal attachments, as well as the duodenum, so that you can get to the IVC. When you get to the IVC, remember that in a damage control operation, particularly, the IVC can actually be ligated below the renals. So while it can make you nauseated to think about it, and it's a scary idea, you can actually live without your IVC. Even if they get significant lower body swelling that requires a later reconstruction, reconstructing and repairing the IVC takes a long time, especially by the time you've gotten to it. So don't be afraid to just ligate it if you need to. Conversely, on the left side, the aorta cannot be ligated in most cases because the lower half of your body does actually need its blood supply. And so having some idea in your mind of how you can quickly repair the aorta and not being afraid to just shunt it and walk away. We've had people in combat scenarios that have a shunt placed in the aorta and actually get transported from one hospital to another with a shunt in place rather than a definitive repair, particularly if you don't have vascular surgery rapidly available. But what is important is being able to get there, stop the blood loss, and get out of the OT. Again, this is just sort of a re-showing. This is an example of a vascular graft. It's actually a femoral artery. I didn't have a picture in the abdomen, but not being afraid to just shunt those vessels and save the actual repair for later to stop the blood loss. Bowel injuries we touched on, whether what you're looking at is ischemic bowel or actual penetrated and injured bowel. Bowel anastomoses take a lot of time. When you first get into the abdomen, you might see stool spilling out. You want to control that contamination, but even control of contamination comes secondary to bleeding. And so not getting caught up in, I see this injury because it's what's right in the middle of the abdomen until you've controlled all of the bleeding. Oversew those bowel injuries, do the resection if you need to, control bleeding from the mesentery. And in the patient who's acidotic, cold, coagulopathic, hypotensive, you have really no business performing a bowel anastomosis or even an ostomy. These are patients that you staple and get the heck out of the OT. Stage 3 of a damage control operation is what we call dynamic reassessment. And this concept just means that you're continually all through the operation reassessing the patient, communicating with anesthesia, because you may find that you get to the OT in a hypotensive, hypoxic, acidotic patient. And if you have good anesthesia, resuscitating, and good hemorrhage control, you may actually get caught up and find that the patient is responding to resuscitation as you stop the blood loss. And while you approach the operation initially planning a damage control, you may be able to safely do that definitive repair if the patient is responding well. Conversely, you may have come to the OT with a patient who seemed stable, but once you opened the abdomen and found bleeding, that the patient is now getting more coagulopathic, more hypotensive, more acidotic, and you need to change your plan from a planned definitive operation to a damage control. So the importance of dynamic reassessment is just remembering that patients are always changing, and you have to continually reassess that status so that you can make decisions on the fly. We'll also talk here, this is an example of the start of a temporary abdominal closure. Yeah, I hope nobody ever looks like this in the OT. But I think the importance of making sure that the patient is warm and resuscitated and you're not taking time to close the fascia. There are certainly times when you can, when the patient will tolerate it, when the abdominal pressure is not high, and you need to leave drains and get out of the operating theater. But in my mind, most of the time, if you're in a damage control operation with an unstable patient, you should not be taking the time to close the abdomen or definitively fix the pelvis. We're just stopping the bleeding, stopping the contamination, and getting out. Equally important to the things you do in the operating theater are what you do in the ICU after you get out. So these patients will get to the ICU. They'll most often be cold and coagulopathic, and the resuscitation that you do in the ICU can be actually more important than what you actually did in the operating room. The concept of a damage control resuscitation was described much later than damage control surgery. And I think it's interesting that as we've gotten better at the actual resuscitation process, the need for damage control surgeries has actually decreased. Because if you can control the resuscitation and control what you give on the front end, you may actually have a more stable patient when you get to the OT. But once you get to the ICU, continuing the concepts of damage control resuscitation, permissive hypotension really only applies before you go to surgery. Once you get out to the ICU, you should have your surgical bleeding controlled, and then we're shooting for a more normal blood pressure. Limited use of crystalloid. It's well proven that the more crystalloid you give the patient, the more you dilute their oxygen carrying capacity as well as their coagulation factors. And so the more crystalloid you give the patient, the more they swell and the less their blood clots. So a guided resuscitation with blood products, whether that's just a balanced resuscitation with a 1-to-1 ratio between packed red cells and frozen plasma, or if you're actually in a center that's blessed enough to have a working TEG or a ROTEM so that you can actually get the details of what your patient's coagulopathy is and direct your resuscitation to specifically what the patient needs rather than a memorized resuscitation ratio. The importance of that resuscitation, though, cannot be overstated. I think both in the ED before going to the OT and after you get to the ICU, the chances that you're going to successfully get back to the OT and get the patient more definitively repaired is totally dependent on how quickly you can get the patient warmed up and resuscitated. And the final stage then becomes definitive repair and reconstruction. And so the question always comes as to when do I go back to the OT? Do I go back on the same night? Do I go the next day? Do I wait 2 days? Do I wait 3 days? And the answer really depends on the patient, on the injuries that you found and repaired, and how the patient is doing, whether they're getting better or getting worse. So described endpoints of resuscitation, things that we're following. My goal is to normalize the patient's lactate, normalize the base deficit, make them not coagulopathic, but also recognizing in the ICU after surgery, the patient who's getting better and the patient who's getting worse may change your timing. Typically, bowel that's left in discontinuity, we think can only stay that way for 48 to a maximum of 72 hours, because even bowel that's in discontinuity is still producing mucus, still has bacteria producing gas, and you risk a rupture of bowel that you've left in discontinuity, particularly if it's a closed loop. But you may have to go back sooner if the patient is getting sicker. So my general goal is to normalize the physiology as much as possible before going back, and realize that you may need more than one return to the OT before you get complete definitive repair and reconstruction in these patients. And with that, I know it's a rapid overview, but I'll happy to take any questions.
Well, thank you much, Dr. Jimmy. It was really informative and scary at the same time, I guess. Yeah.
Sorry, Haider, I was on mute. Thank you, Jamie. So questions, I think you answered most of the questions. I have only 2 for you, again, for the interest of time, and for questions for Dr. Bala and for everyone else. If you have time at the end, we'll answer them. So Jamie, what's your damage control maneuver to deal with an expanding retroperitoneal hematoma?
So the expanding retroperitoneal hematoma depends largely on what zone it is in, and I didn't touch on that. If you're looking at a midline zone 1 where you think you have a great vessel injury, then the maneuver is proximal and distal control. That may be a supraceliac clamp. At times that means going into the chest to get proximal control depending on where it is, which can be terrifying but also can be rapid if you know what you're doing. Your distal control, remember, you have to get both sides of the iliacs, and so that may be in the pelvis, that may actually be in the groins, and so don't be afraid to move all the way to the femorals if you have to get distal control on those vessels. We talked about the IVC and the ability to ligate it. In zone 2, out laterally, when you're talking about injuries to the kidneys, often the definitive or the rapid, if you can't control that with packing, just take out the kidney. So if the kidney's killing the patient, put the kidney in a bucket. You generally don't recommend doing that with both kidneys in the same operation, but people have lived on dialysis without kidneys. It's certainly not ideal. And in the pelvis, I think the mainstay is really packing. And so being familiar with the approach to get a pre-peritoneal pack and just fill the pelvis up, both with external compression to minimize the volume of an open book pelvic fracture and pre-peritoneal packing.
Okay, Jamie, question from Dr. Bala here. What's your experience with using intra-aortic balloon pump to stop the bleeding distally?
So not an intra-aortic balloon pump per se, but a Reboa balloon catheter can be very effective in the right patient. What's important to recognize is that there's not an injury in the chest and that balloon can actually stop the bleeding and getting it in appropriate places. But I've had patients that did very well if you got it in quickly enough. If you're not experienced with the Reboa or you don't have it rapidly available, sometimes it's quicker to just open the chest and put a clamp on the aorta.
Excellent. Thank you, Jamie, for that. So I think just for the interest of time, we'll move to our third presentation. It's again, blunt abdominal trauma, the role of the intervention radiologist, and Dr. Patil is ready to go.
Assalamu alaikum and good evening. I'm Shabazz Patil, interventional radiologist at Sheikh Shakur Medical City. My talk is about blunt abdominal trauma and the role IR can play in this. And the background picture is this is how our premises look if you go outside now. So the milestones in IR managing trauma would be incomplete if I do not mention about the father of interventional radiology, Dr. Charles Dotter. This is what he did to our specialty 55 years ago, and a new specialty was born. In 1973, the first report of internal iliac artery embolization following a pelvic fracture was published, and it took for the second publication to come after 20 years, which was a covered stent graft for a subclavian artery injury. This was an iatrogenic subclavian vein puncture failure. As we all know, time is very important in managing trauma. We have learned from our medical school days, the golden hour. And same goes here. From the time of injury to stopping the hemorrhage, if there is delay, the outcome gets affected. So transferring the patients in a radiology department from one room to another room is time consuming. So the newer concepts is integrated or combined CT and angiographic units in the major trauma center in the Western world. This is one of the concepts where you have a CT scanner very next door to the angiographic suite, which is interconnected with a door in between. Straightway, the patient comes to the trauma scan and goes on the angio suite without wasting any time. But a step ahead, next is get the CT scanner in the angio suite itself so that you do not waste any time. Important factor when we are dealing with such major injuries is speaking a common language. I like this quote from Susan Baker, that if you never felt the need of any time of severity scoring system, then how you can say or explain that the survival rate of 85% in your major trauma center is better than 97% in a district general hospital where the trauma patients are much less severely injured. There are around 50 odd type of scoring systems currently, but the most commonly used language is this by American Association of Surgery or trauma. We divide trauma management into non-operative and operative. And where does IR stand? We come under the non-operative management group as an adjunctive. So let's start with our first case. Is a 23-year-old male who fell from height of 3 meters. This is a CT angiogram where you can see on the arterial phase slight blush within the spleen, which increases on the portal venous phase. We did a angiogram of the celiac axis, went into the splenic artery. Superselective angiogram showed the blush around the splenic hilar or / parenchymal region, which was embolized with coil and liquid embolic material. And this is the final outcome result. So AAST classification says the grade 3 and grade 4 injuries are the one which are managed by interventional radiology, and grade 5, they go to surgery straight away. So embolization in splenic trauma. When they arrive in ER, most of them are remains uncompromised. What we pick on the CT angio is pseudoaneurysm, contrast extravasation, or AV fistula. If we do not manage these at an early stage and left them untreated, there is 20% chance risk of splenectomy for these patients. And the patients who go for delayed hemorrhage are the high-grade injuries, like the grade 3 and above, and patients who require more than 1 unit of blood transfusion on admission. It would not be complete if we do not mention about proximal embolization versus selective embolization of spleen. What is proximal embolization? It is similar to a surgeon going in and ligating the splenic artery proximally. We use permanent embolic materials like coils and plugs. For us to do this is much quicker compared to doing a selective. And the patients which we do these for are the diffuse injuries, or our skills are not good on that day to get into selective embolization. It has lower non-operative failure rate and less infarction and abscess formation if we do proximal embolization. On the other hand, if we do selective, we may miss some other bleeding points because of the physiological spasm secondary to bleeding at that point. It takes a lot of time because we have to use microcatheterization. But the positive aspect for selective is the splenic artery remains patent so that we can re-intervene anytime. But the negative aspect, there is high infarction rate and higher rate of abscess formation. So what do I quote when I talk to patients or relatives about the complications? 19% have major complications, involve mainly the infarction, rebleeding, and abscess, 11 and 3%. The last two can be managed easily because we can go back in as many times as we went. And abscess formations, we can drain them as many times as we want. Overall, the complication rate is less than doing an open surgery. Next case we move on is a 22-year-old male patient who was involved in a motor vehicle accident in a different hospital and was discharged. He came back to the hospital again 4 days later with a left upper quadrant pain. CT was done in the referring center and then transferred to us. And if you see on the CT angiogram, the arterial phase which shows blush within the spleen. On the coronal, it is confirmed. And then we did celiac angiogram and then selective. And you can see the blush next to the dome of diaphragm on the left side. And then we have to embolize using coils and liquid embolic material. So the point we learned from this case is how important is follow-up imaging. I don't have the first imaging when this patient was presented to the referring hospital, but what the literature suggests that pseudoaneurysm can develop 48 to 72 hours later. You don't see anything on the first scan. It doesn't matter how severe the injury was, and these remain silent until they rupture, which means that there's no data to say what is a rupture risk. What the incidences of pseudoaneurysm in post-trauma is between 4 up to 6%. And people say about ultrasound follow-up imaging, which I say is useless. We have to do a CT angio. So at our trauma center, what we do is, irrespective of the type of injury, we repeat a CT angio before the patient gets discharged from the hospital. And this is the algorithm which we use for splenic trauma. If there is active bleed, and if patient is clinically unstable or compromised, straight to the theater. Otherwise, discuss with interventional radiology. Grade 3 and above injury, irrespective of arterial blush is seen or not, needs to be discussed with IR and further management. And as I said, we have to repeat a CT later. Our third case is 30-year-old female, bicycle handlebar injury. This is a CT angio. You see within the liver parenchyma, there is arterial blush. And then we went in doing a conventional angiogram of the celiac axis, went into the right hepatic, and which did not see the blush. But based on the CT finding that the location, we used a temporary embolic agent, which is we call gel foam, and then we came out. That's why, as interventional radiologists, most of the time when people call for embolization, we always ask for a CT angio before we go in. There are two reasons for that. Is A, it saves our time to look for going and hunting for bleeding points. And second thing is, even if I don't see a blush, because CT angio is more sensitive than a conventional angio, based on the anatomy and the artery which we see on the CT angio, we can just use a temporary embolic agent. Next case is a 19-year-old patient, liver trauma. This was initial presentation, trauma scan, big blush of contrast within the liver. Patient was taken to theater and then sent to IR angio. We did a very good conventional angiogram. Here you can see the common hepatic and the right hepatic. We don't see the blush, which was seen on the initial CT. So initially we thought probably that bit is completely occluded, so we don't have to do anything, which was a lesson I learned. Left the patient a week down the line before discharge, as is our protocol. Patient had a repeat CT which showed next to the necrotic area a big blush again. This time we went back in and found the pseudoaneurysm and embolized with coils. So as per the AAST classification, it's quite same as the splenic injuries. Grade 3 and grade 4 are angioembolization. What are the complication rate we quote? Mostly is the parenchymal necrosis between 15 to up to 43%, depending on the severity of the injury to the liver. And non-selective embolization is more when a liver is lacerated at multiple areas or multiple parenchymal bleed is there. And if there is an associated portal vein injury, then the parenchymal necrosis rate goes up. Bile leak or bilioma is up to 20%, which we can manage through interventional radiology. Ischemic cholecystitis up to 15%, most commonly in the lower segments on the right side because of poor visualization of the cystic artery in this major trauma patients who are hemodynamically they have lost a lot of blood. And then post-embolization, you see abscesses or collection in 7.5% and delayed hemorrhage up to 10%. In complex hepatic trauma, there was an article published which says that if mortality rate up to 12% with post-embolization, but if you don't do any angioembolization, the rate can be 3 times higher. So the trend is now in liver trauma moving more towards interventional radiology, which is non-operative management than opening treatment. Delayed surgery after angioembolization was seen in up to 20%, and it's mainly because 3/4 of these patients had abdominal compartment syndrome, which was triggered from massive bleeding. And more than half of the cases were managed laparoscopic lavage and drainage. And more than 70% of the complications can be treated successfully with minimal invasive management. And this is the algorithm for hepatic trauma, which is similar. If it's called patient, you see the blush on the arrival CT angio. If it's clinically compromised, they go for surgery. If not, IR. And if the patient do not see any blush and if the patient clinically looks compromised, then you can observe or discuss with interventional radiologists. This is a very interesting case, 22-year-old male, road traffic accident. The injuries on this slide shows that what kind of patients we receive in our hospital. There is grade 4 liver injury with arterial blush. There is renal injury with hematoma and arterial blush, adrenal injury with arterial blush, and also anti-abdominal wall arterial blush. So you can see the severity of the injury. Patient was resuscitated in ER with fluids and major trauma protocol. A right chest drain was inserted in ED. Patient straightway was sent to theater for level 1 exploratory laparotomy with bleed, and packing was done. Abdominal was not closed. And then straightway from theater, patient was brought down to IR and on the same day. So what we did, this was the CT when he arrived in ER. You look at the liver and the severity of the injury. This was the kidney, which showing multiple areas of blush. And this is the coronal section. The reason I'm showing you this is 1/3 of the part of the kidney is still enhancing very well, but there is a vessel which is going inferiorly from the main renal artery, which is truncated. So this is the picture when patient goes for laparotomy. So it will be very difficult for us to see any small blush. So this gentleman had right renal, multiple areas of blush, and still this much of the kidney was enhancing. But if you see that truncated vessel here, and if we leave this, trying to go for more selective, the chances of him rebleeding will be much higher. So to save his life rather than the kidney, we had to embolize his whole kidney. And then we went looking for any blush if we can find in the liver, which was already packed very well by my surgical colleagues. And for our luck, this patient had a replaced right hepatic. So we had to go into the SMA and then do angio. Luckily, there was no blood seen. And this is 10 days later, the liver, no blush. But if you can see, this is the previous hematoma from the injury, and this is iatrogenic necrosis from our embolization. So in kidney, as keeping in mind with this case, 75% of the renal injuries will have a second organ injury. Like this gentleman had 3 or 4 organ injuries. Blunt injury is common, up to 90%, and mostly managed nowadays with non-operative management. But if you'd have gone a decade back, this patient would have gone for a nephrectomy straight away. 64% risk of nephrectomy in the past. It's all historical now. And that's a AST classification, which says again grade 3 and 4 can go for angioembolization. The outcomes, study looked at 5 years data with renal injuries. 77 patients underwent angioembolization, out of which 60% were grade 4 and grade 5 injuries, and 36 patients required a second embolization. That is the benefit of IR. We can go back as many times as we want. 97% were successful. In another study, they looked at the renal function in 17 patients with grade 4 renal injuries, followed with the dynamic scintigraphy post-embolization. Renal function was preserved in all the patients. And then another study looked at blood pressure, which looked at 41 patients, out of which 9 patients required starting of antihypertensive drugs. Out of these, 3 were never hypertensive, but they had to be hypertensive post-embolization. And another 6 had to add a new antihypertensive drug. My talk would be incomplete if I don't touch a little bit on the pelvic fractures. In CT angios, 99.6% of the time, if you don't see any blush, that's fine. You don't have to think of doing anything more on that. Venous bleeds are common, 90%, and massive bleed is mostly arterial, up between 10 and 20%. Venous bleeds, as we all know, can be managed with pelvic binders and temporary stabilizers. Until we don't fix the pelvics, the bleeding will never stop. And ongoing hemorrhage can lead to 54% of early deaths. And surgery, doing any open surgery for these patients causes more disaster by decompressing the hematoma. So which patients needs coming to angio room? Pelvic fractures with hemodynamic instability, or patients who are showing signs of ongoing bleed after we have ruled out all other non-pelvic source of bleed. This is level 1 recommendation. They should be taken for a conventional angio. Second group, evidence of arterial IV contrast extravasation. Yes, it's a level 1 recommendation. Or patients who have pelvic fractures already have been to the angio suite with or without embolization and now have signs of ongoing bleed. And we have ruled out no other source of bleeding. This is a level 2 recommendation, but can be taken to angio. This is the outcome, successful hemostasis, post-embolization in pelvic fractures up to 100%. Repeat embolization was required in 10%. Mortality after successful was between 7 and 40%, but due to pelvic bleeding was only in 6%. Complications mainly local complications like groin hematoma, non-target embolization, or any abscesses in 1%. The future of trauma is patient comes straight after CT angio to us for embolization. Not just embolization. We'll put an IVC filter in the same sitting. We'll do a chest X-ray and we'll insert a central line for the patient because we are already given an access to put IVC filters. So I can come out putting a central line. I can do a cystogram on table to rule out any bladder injury, and we can also help with lower limb X-ray. So it's a one-stop trauma store. Thank you. This is how our premises look in the morning.
Good. Thank you, Dr. Matir. Again, great presentation. Thank you for that. So I again ask two questions. First one from Dr. Amr Al-Hani. What's the impact of the COVID pandemic on interventional radiology?
Our center, for the last 4 months, we did not stop our elective work, and because we are a trauma center, the trauma embolization cases went on with the same. So I did not see any decrease in the number of trauma cases.
Okay, good. So the second question is, what's your pathway for solid organ injury in children? So what's the difference between kids and adults in your practice?
In our practice, we do not see much of trauma cases at SSMC in terms of pediatrics because they go to SKMC. So we rarely see any trauma cases here.
But do you think the protocol, is it the same or is it different for children?
I think it will be nearly the same.
It's the same. Okay, so I think we'll leave the questions to the end. We'll move to the last presentation, and it will be coming from Dr. Ahmed Al-Sayari, who is our trauma consultant, general surgeon, trauma and acute care at SSMC. And he will be talking about epigastric stab. So we are leaving the blunt trauma to the penetrating trauma now. Dr. Ahmed, can start. Ahmed, just unmute yourself. Unmute.
Sorry, I was getting difficulty in unmuting. Okay.
Yeah, okay, now we can hear you. Okay, share your screen and.
Okay, can you see it?
No.
I just shared it.
Okay, go ahead.
Can you see now?
No, we can't. Stop sharing and sharing again.
Just share again.
Okay.
Yeah.
Yes, now I think it's coming now. Okay, now we can see it. Yes.
Okay. First of all, thank you for giving me this opportunity to join everyone. Assalamu alaikum, good evening, everyone. I'll be discussing short and simple case that presented to our facilities few months ago. So it was a patient who presented to us, 46 years old male patient, known with psychiatric illness, presented to our emergency department with history of self-inflicted stab wound to epigastrium. Basically, this patient used to imagine that somebody is sitting over his chest and causing erectile dysfunction for him. So he took the knife and tried to stab him, and he stabbed himself. So when he arrived, he was hemodynamically stable with GCS 15/15. So first of all, first question we ask ourselves, what are the organs at risk? So if you see in this picture, basically we are dealing with epigastric stab. So liver, stomach, cardiac injuries, lungs, and probably the spleen. So these organs are at risk, and we have to take them in consideration when we go further with this case. So on focus examination, abdomen was soft, non-tender. There were no signs of peritonitis. He had good air entry bilaterally. There was no signs of raised JVP, and patient can lie in bed comfortable. So basically, the last two signs indicate if the patient has tamponade or has any signs of cardiac injury. So what is the next? Previously, many people used to go to operating room for wound exploration, but I wouldn't do this with this patient basically because he's very stable patient. So I have choices to investigate further. So the first thing I'll do the chest X-ray. Unfortunately, this patient didn't get chest X-ray, and I'm sure Dr. Bala wouldn't be happy about it. So directly the patient moved to CT scan. So the first thing you have to do chest X-ray, rule out if there is any pneumohemothorax. Then maybe ECG to make sure that the patient doesn't have cardiac injury or indicate cardiac injury that you can see it through Q waves in ECG. Ultrasound is an option, but it wasn't used in this case. So ultrasound, you can use it to check for pericardial effusion and free fluid in the peritoneum. Many hospitals with limited access for CT scan depend on ultrasound combined with clinical examination. So, but the disadvantage of ultrasound is it is very much operator dependent. So the hospital I was trained in, we used to depend on ultrasound epigastric stabs completely. We never used to do CT scans. So basically we check for pericardial effusion, if there is pericardial effusion or not, and then clinical examination, serial clinical examination for abdomen. And we admit the patient for observation for 24 hours. But in Sheikh Shahbout Medical City, we have the advantage of having a CT scan, which is a good option to use. So this patient got a CT scan. I'm not sure if the internet will be quick enough to see. So basically, this is the CT scan of the patient. And if you can see here, there is lots of fluid around the heart. Then you start seeing here very soon you'll see some free air coming to this area and this area. Then you see the rectus muscle on the left side is big, and this is the site of the injury. Otherwise, there was no free abdominal fluid or air in the CT scan. Okay, this is another video for the CT scan. And again, you'll see this is the liver. So again, you see fluid around the heart. This is not air, but the air will come. This one, you can see some free air here, then free air in the soft tissue. Okay, so it's very important to remember, not every abdominal injury is an abdominal injury. So abdominal means if you have an epigastric stab, you have to keep in mind that maybe there is some thoracic injury. So what is the management? We have free fluid around the heart. So are you going for a sternotomy or observation with sub-Ziphy window? So basically, previously, the standard of care practice internationally was sternotomy for any pericardial effusion and go for cardiac repair. Hemopericardium was detected after penetrating chest injuries. The experience in South Africa with high volume centers was that the sternotomy was unnecessary in most of the cases. So basically, they had lots of cases of pericardial effusion, and when they open and do sternotomy, the injury didn't require actually sternotomy to repair. So the injury was basically sealed, or there was nothing to repair there. So what they have some background before moving on. So only 11 to 20% of the patient with penetrating cardiac injury will arrive to hospital alive. And the clinical presentation can be classified into lifeless patients or critically unstable, patients with cardiac tamponade or thoracoabdominal injuries, or benign patients. Out of the patients who arrive alive to the hospital, 15 to 30% are benign. So what did the Cape Town surgeon have done? Basically, they conducted a pilot study in 2001, and they found that 71% of the patients had non-therapeutic sternotomy. Next step for them was they managed 7 patients with pericardial fusion without sternotomy, and they just did sub-Ziffy window with drainage. So this is the study which was published in 2013. And I think Dr. Salim was a registrar at that time, and he took part in this study. So the method of the study, it was a single center study in Cape Town at Groote Hospital. It was over 7 years period from 2001 to 2009. All the patients, inclusion criteria included all the patients above 18 years of old, sustained pericardial injuries, who are hemodynamically stable with confirmed hemopericardium on sub-Ziffy window. And there was no signs of active bleed. So basically they opened it, they did sub-Ziffy window, they checked if there is blood and there is no active bleed, they used to randomize the patient either to just drain them or to continue with the full sternotomy. So all the patient management protocol was all the patient had chest X-ray, ECGs, pericardial ultrasound was done in resus room by on-call radiologist. Any free fluid in the pericardium was considered to be a positive for blood. Patients were admitted in high care observation for 24 hours and underline that 24 hours. Then sub-Ziffy window was done after 24 hours. If they found blood, they used to randomize them, either sternotomy or drainage. So overall, over 7 years, they got 348 patients who had surgeries. 191 patients of the 348 were hemodynamically stable. Out of that, 80 patients were excluded for different reasons. So some of the reasons that they had 11 patients under age of 18 years old, and many of them had active bleed. Some of them, they have septic pericarditis. And to underline something, 36 patients had negative sub-Ziffy. Basically, they had pericardial effusion, but there was no blood in the pericardium. So in the sternotomy group, 93% had no injury or just minor injury. And if you see in this table, around 93% had very minor injuries that didn't require, and only 4 patients actually benefited from sternotomy. That was in the sternotomy group. Coming to the pericardial drainage group, there was no grading, but all the patients did well. None of them needed any surgery further, and they were discharged. So according to classification of complications, you notice here, most of the patients had, both groups has basically similar kind of complications. If you see from grade 1 to grade 3, all of them, both groups have similar complications. But coming to the grade 4 and 5, you notice that the sternotomy group have 1 cardiac arrest and 1 sternal sepsis and 1 death. So the cardiac arrest basically happened spontaneous during the sternotomy, and the patient was survived after resus. The sternal sepsis, also the patient survived, but needed multiple debridement and operations. The last patient who died, basically he died because of internal mammary artery injury. So after they finished, the patient was transferred to ICU, he was unstable, then they discovered that the patient has internal mammary artery injury. So that shows you actually sometimes the unnecessary operation can lead to death. So ICU and hospital stay, there was significant difference between sternotomy group and drainage group. The sternotomy group had around 2 days in ICU, and drainage group around quarter day. And the hospital stay for sternotomy group was 6.5, and the drainage group was 4.1. In conclusion, pericardial drainage is an effective and very safe method of managing patient with penetrating cardiac injury. But I add to that the hospital which manages these patients in this way have to be high volume center, and the doctor should have enough experience in deciding which patient should go immediately for operating or not. So coming back to our patient, what we have done, patient was admitted to ICU for observation. After 30 hours, he had sub-Ziffy window. We drained 150 ml of blood, and we just kept a soft drain there. We washed out, we waited for some time, there was no active bleed, so we closed with the drain. Next day, the drain was less than 50 ml. There was no blood in the drains, so the drain was removed and patient remained stable. We did echo post-operative to make sure that there is no endocardial injuries. Patient was discharged second day of hospital stay to another hospital for his psychiatric illness. Thank you. That was very short and
sweet. Thank you, Dr. Ahmed.
Thank
So
you.
2 questions again. Do you do any cardiac enzymes or echo before surgery?
Look, I don't do tests that won't change my management. If I have a diagnosis of cardiac injury, I don't need them to prove it. So if I have a pericardial effusion post penetrating injury, I'm going for operation anyway. So how it would change my management?
And it said again, another question from the same doctor. What sort of a drain did you leave in this patient?
Yeah, we didn't have the usual drains which I used in Cape Town, so I just used the normal JVAC drain.
Okay. Another question from Dr. Makki, Haider Makki, is do we need to explore every single patient with penetrating injury? You know, the classical teaching was for penetrating injury should be explored. What's your opinion on penetrating
No,
injury?
I don't do that, and I think Dr. Fitch agrees with me. Now we have lots of advancement in our radiology. So basically, I admit the patients and observe him for some time. If he needs an operation, I'll go for the surgery. If he doesn't need an operation and doesn't need sheath repair for his abdomen, I just discharge the patient.
So Ahmed, the patient with gunshot to the abdomen, entry and exit through the liver, would you explore them or you will conservative management?
Again, I'll follow the same protocols of trauma. If the patient doesn't have a reason to go for operation, he's stable and can be managed, and non-operatively, I'll go for non-operative management. Operative management comes in, means if he's unstable, yes, I'll go inside to pack. Otherwise, I'll just do the CTA and depend on interventional radiology if I need something.
Okay, so now we are doing more conservative and conservative. If the patient is
Yes,
stable,
exactly.
room for conservative management always. If the patient is unstable, then go for surgery. So I think that concludes our presentation from SSSMC. I think we will hand over back to our host, who is Dr. Haider and Dr. Adnan. If they have any question or they have cases to discuss with us, we are happy to do anything you like. Or if you want us to answer the questions on the chat, it's up to you.
I think, Dr. Salim, you go back for the first 2 presentations. There are a lot of questions. You can go through it and try to, with the colleague, to be answered because.
Okay, so Dr. Bala, there are lots of questions for you. You can come close to the mic. Oh, I lost the questions now.
He has on his phone.
Okay.
Can you read them?
Dr. Bala prepared some of them, so you can say the questions and answer the question. I can have it here.
I'll read.
So one question was on pancreatic injury. How do you diagnose pancreatic injury? What are the signs on CT scanner for pancreatic injury?
Okay. Sorry, it's me again, Dr. Bala. Pancreatic injury is usually, to start with, it's a difficult area to diagnose, number one. What are the signs you look for is you start from swollen edematous pancreas with or without fat stranding. So that will become one group. So you have a swollen pancreas, edematous with peripancreatic fat stranding, but not much in the fluid, normal enhancement of the rest of the pancreas. That will be like mild. And you actually follow the grading, and then you go disruption to the parenchyma, but no ductal disruption, meaning that the duct is intact. How can we say the duct is intact on a CT scan? I use a rule of thumb. If the laceration does not go more than 50%, it is less likely to involve the duct, meaning that usually the duct runs in the middle. If your injury is involving only less than 0.5% of the parenchymal thickness, then it's less likely. Then you have a rule to follow up. You may need to do a MRCP, or you may even need to do a ERCP in those groups. The The other two groups are very straightforward. When there is a complete laceration or a transection through and through the pancreas, then that goes to the surgical hand. The surgeon will decide. Usually when there is a transection on the pancreas, they leak. When they leak, then they need to manage accordingly. Why do we need to know whether there is a complete transection or an incomplete transection? There is a role for ERCP and pancreatic stenting. If there is an incomplete transection, you might still do a non-operative management. That's when the MRCP comes in, or you can even go for a direct diagnostic ERCP, which is more reliable than MRCP because you are actually injecting contrast dynamically. So you can bring out and see whether there's a duct disruption or not. So in nutshell, you look for the edema, you look for the hemorrhage. One of the signs they say is hemorrhage between the splenic vein and the pancreas, hemorrhage around the head of the pancreas, fat stranding. But in my experience, when you see pancreatic injury, they're always associated with other injuries. That's when it becomes a dilemma. You have a splenic laceration, you will have a liver laceration, you will have duodenal contusion. So I put them together. Pancreatico-duodenal complex injury, but no fluid around it. Pancreatico-duodenal complex injury, is there extraluminal gas around it? If there is extraluminal gas, then it's over to surgeon. Because you have a perforated duodenum, then they need to decide what to do with it. So in a nutshell, you can go along the ASST criteria, mild to moderate to severe. So what is our role is to look for it. First of all, we need to look at the pancreas and make sure there is no injury at all. That's the only way to avoid missing pancreatic injury. Because we get carried away by looking at other injuries. That's when the problem arises. I'm not going to say that nobody will miss it from today onwards. No, it will be missed because all these patients will have concomitant organ injuries. So unless you look and ask yourself, am I clear with pancreas? Am I clear with pancreas? That's a question you ask yourself before you say pancreas is normal.
Okay, another question. What's the role of MRI in imaging of a pregnant lady who's a trauma victim? So when do you do MRI on a pregnant lady? This question said who's clinically stable.
Okay, the management of trauma in pregnant lady is totally a different game. Why do I say that? There are lots and lots of recommendations. The Royal College of Obstetricians recommendations follows a simple. What they say is the best way to take care of the baby is to take care of the mother. Okay, so that's what it matters. What I'm trying to say here is if you think the patient has got significant injury, do not worry about radiation. Okay, you have to assume that you have to save the mother to save the baby. So that's one major thing. You have to get it inside your mind. It is a difficult decision. The decision has to be made by multiple team, surgical consultant, ER consultant, or whoever is available. Needs to be a good discussion with the family, but you have to mention that the best way to take care of the baby is to take care of the mother. So you follow the same protocol. The radiation, we do CT scans of the babies. Okay, so we do CT scans of the baby. Yes, there is a radiation risk, but what if there's a significant injury? That is one group, okay? The second group is we often measure the blood pressure and hemodynamic assessment done on the pregnant ladies. Blood pressure, vital signs, urine output, symptoms. But we often forget the fetal monitoring. According to the Royal College of Obstetricians recommendations, any trauma patients, any trivial trauma, even if it is a trivial trauma is the one that causes big damage to the fetus. Major trauma kills the mother, that's what the wording says. Minor trauma kills the baby. So you need to have a fetal assessment, cardiac fetal assessment. Why is that? Fetal distress is the first sign of maternal hypotension. So we need to get this in our mind. Patient may be stable. We think the patient is stable, but if the fetus is under distress, that is telling you there is maternal hypotension. Okay, the question answered to me is the MRI scan. To be honest, if I have time to do MRI scan in a pregnant patient, I assume the patient is well enough. So basically, You have done your ultrasound, you have done your chest X-ray. Chest X-ray is not a contraindication, believe me. Chest X-ray is not a contraindication in a pregnant patient involved in trauma. If you done a chest X-ray, no pneumothorax, no lung contusion, no major fractures, then you do an ultrasound. You are talking about a stable patient here. Your urine dipstick is clear, observation is clear. I think the role of MRI, I'm not sure what is the role of MRI. You can do MRI to say it is normal, but there may be some group might say, I don't need to do an MRI to say it is normal. The patient is normal otherwise. So stable patient, meaning that MRI you can do to look for fluid, which we can pick it up on ultrasound. So I'm not sure what is the role of MRI. You can do it. It's not going to stop you. There is no contraindication, but if the patient is already stable, then it is stable. And you have done your basics. You've done your ultrasound, you've done your X-rays, and you've done your fetal monitoring. Do not forget the fetal monitoring in maternal trauma.
Okay, Bala, one more question for you from Dr. Abdul Wahab. If the patient is hypotensive, does hypotension mask the radiological signs of bleeding like extravasation of contrast and blush?
Our experience is the answer to the straightforward question is yes, because we see that very often in on-table angiogram. When the patient goes into spasm, the vessel goes into spasm, which means that the splanchnic circulation. So the blood supply maintains to the heart and brain, the rest is compromised. But you will see truncation. That's what I meant. Radiologist must understand the hypotension complex. If you can understand the hypotension complex in a CT scan, then you convey that message to the babysitting clinician, saying that there is significant hypotension complex. That meaning that the patient is bleeding somewhere, but I am not finding it. I have got experience in patients who are on inotropes. I have seen so many times when the patient is on high dose inotropes, comes for a CT scan, they get truncation. The SMA gets truncated. The renal artery gets truncated because that's what the effect of inotropes is. So patient is, that's telling me this patient is in dire state. Yeah, it will mask, but you have to pass that message to the looking after clinician.
All right, one maybe last question for both of you here. If you find a multiple pseudoaneurysms in the spleen, there is no blush, patient is hemodynamically stable, do you embolize the pseudoaneurysm or you just do a follow-up CT scan?
I will try and answer. I think my colleague will help me with that. I learned this lesson from a Dublin group presentation that what we used to think there is this splenic rupture happens after 2 weeks in a blunt abdominal trauma. Then the great father asked the question, why would a normal spleen in a normal patient ruptures after 2 weeks? It shouldn't. Is a normal healthy patient, why would the spleen rupture? Because it is the pseudoaneurysm that ruptures, not the spleen that ruptures. So I hope I answered your question. We cannot ignore knowing that there is a pseudoaneurysm in the spleen, because I cannot prescribe you. We can do a scan every 2 weeks and 3 weeks and sit tight, because there is a risk of rupture.
Okay, Dr. Batil, any comments?
That is where my slide about the algorithm suggested in 48 to 72 hours, irrespective of the patient being stable, as we do at SSMC, we do a pre-discharge CT angio, irrespective of patient stable or not stable. And if we see the blush, we straightway go ahead and embolize, because these are like time bombs. You might just send them away and next day the patient collapses and loses his life. So we have to embolize.
This patient didn't have a blush. He just has multiple pseudoaneurysms, but no blush.
So you have seen them on the imaging as pseudoaneurysms. I'll go ahead and embolize.
You will embolize. Yes. So the answer, Fatima, is they will embolize. Okay, Haider, talk to you again.
Well, thank you, Ammi Salim. Thank you, everyone, for the nice, great presentations. I have a couple of scenarios. If you may, Dr. Salim, I'll present it. I'll ask you to manage it. Now, first scenario, can you see my screen? Right?
Share the screen, we see part of it.
Can you see it?
Yes.
So, stab wound in the left lower chest, 8th intercostal space, CT showing omentum herniated through the left hemidiaphragm. Otherwise, no other injuries. So, we go in, go by the laparoscope, we reduce the momentum, we repair the defects. My question is, if you have the CT scan saying there is nothing except the diaphragm injury, would you take also a general look to the abdomen? Would you open the lesser sac and check the posterior of the stomach? Would you run the bowel from the DJ down to the lucica or down to the rectum, or you just been satisfied with the CT findings?
Okay, let me direct questions, yes, to Ahmed and Jimmy. Yes, Ahmed?
From my side, I think, again, I told you stab wounds, I admit for observation for 24 hours, or and I'll see if the patient developed peritonitis or not. If the patient CT doesn't suggest any injury to pancreas or any hollow viscous injury, plus the patient is stable and didn't develop any signs of peritonitis, I'll just go laparoscopic repair the diaphragm and come out. I don't know what Jimmy thinks.
I think very similarly, if you have a hemodynamically stable patient, you have a CT showing that you clearly have a diaphragm injury, that's a patient it has to be repaired, does not have to necessarily be repaired in the middle of the night, particularly if you're in a busy trauma center with other things going on in sicker patients. That's something that can wait for the daylight, 24 hours or so, but has to be repaired. I generally, if I'm in the abdomen on a trauma, I'm gonna do the look around for good measure. As long as I'm not risking the patient by doing so. So I think that the board exam answer, if you're in a testing scenario, is a full diagnostic laparoscopy and running all of the bowel. In practice, would I necessarily run all of the bowel in that scenario? It probably depends on the stability of the patient and previous surgical histories and what I think the risk is. But generally looking around at least to the right upper quadrant in an isolated stab wound.
Yeah, the patient is completely stable and the CT is negative except the diaphragm, but you, Dr. Jimmy, still you run the bowel to make sure you just run it fast or?
Most of the time I would, yes. And now if I had a patient that had previous surgical history and had adhesive disease and I was putting the patient at risk, you know, I would not go diving into adhesions. And so it's always a risk benefit balance. But in an otherwise virgin abdomen, I would probably examine the bowel.
So Haider, I'll have a look. There's no harm to have a look, but I wouldn't open the lesser sac or mobilize anything, but anything that's, I can have a simple look, I'll have a look. And we always do that, but I wouldn't go open the lesser sac and look for things unless it's in front of me.
Second scenario is a stab wound in the left flank. The omentum is protruding. The patient is completely stable, vital, CT done. There is no bleeding inside the abdomen. There is no bowel injury except this omentum herniating outside. So,
okay, again, Dr. Ahmed, omentum, only no bowel.
Nothing except the omentum is protruding.
And the patient is hemodynamically stable.
Totally stable.
Yeah, I would take this patient to theater to reduce the omentum internally. It looks, from the picture, it looks quite big defect. So probably I'll go for laparotomy exploration and reducing the omentum, repairing the sheath.
You do a CT before you take him, or you take him? He's stable.
I would look, if he's going for, I'm taking him for theater anyway. I wouldn't do CT, but I know many doctors prefer having CT to see if there is any unexpected things. But personally, I wouldn't do CT scan if I'm taking him for laparotomy anyway.
Okay, and for a large wound like this, would you repair it like a primary repair, or would you put a mesh? Most of those patients are heavy workers, like either constructors or whatever.
No, I would do primary repair.
Primary repair, okay.
Well, Jimmy, what do you think?
Yeah, I agree with Ahmed. I think this patient has an indication to go to the OT, and a CT scan is not going to change that. And so I would go directly to the OT. I would repair this in 2 layers. You need, in that location, I think this was upper abdomen, you need to get both the posterior and anterior fascia. But unless there was a fascial defect, meaning from a gunshot wound or something, it was missing and under tension, I would likely just primarily repair it.
Okay, so question for both of you. Why don't we just excise the omentum, reduce it, and close the wound from outside? Do we need laparotomy in this case?
I think you need a full exploration of that area of the abdomen, whether that's with a laparotomy or a laparoscope, depending on the patient's stability. I think that there's not a reliable way to know that's the only injury. And when you have a penetrating injury that you know violated the peritoneum, you have to prove the bowel is not injured.
I agree with that.
So Next scenario, this a worker fell from some height, construction building, and he felt on his left side of the abdomen. The skin is intact, but the muscles obviously teared up. What's your plan? Would you also take him for a diagnostic? He's completely stable. There's nothing wrong with him. Vitals stable. CT, there is no injuries except the abdominal wall. So, would you have him for a diagnostic lab, or would you just admit him for observation? Would you repair the teared muscle or not? On both whether elective or basis.
Jamie, what do you think?
I think that what I see in that one cut looks like this is a defect all the way through through the full layers of the abdominal wall. Is that correct? So it's a hernia, it's a traumatic hernia, and that needs to be repaired. It's not something that needs to necessarily be repaired emergently in the middle of the night, but I think it does need a repair. So you have the options there depending on your center and what your resources are at night to go acutely and fix it, or to do serial abdominal exams, monitor the patient overnight, and potentially laparoscopically repair it. But I would think that does need to be repaired.
No, he's completely fine the next day morning. So would you go open or laparoscopic repair?
Ahmed, what do you think? Yeah, Jamie, go ahead.
No, go ahead. That's fine. Go ahead, Ahmed.
Okay. First of all, I think this patient had a strong impact to tear his thick muscular layer. And I would go with laparotomy to make sure there is no blunt injury to the bowel or some ischemic segment that won't show easily. I had similar case, which patient was completely stable. Everything looked fine in the patient, skin intact, but showed the similar finding in CT scan with the big tear in the muscles. When I opened, I found segments of bowels which were ischemic, and I resected and I did anastomosis. So in this case, I think I'll go for exploration. Reduced, yeah. I'll go for exploration. No, I'll go for open. But laparoscopy in trauma is limited. Means people like trauma surgeons don't like laparoscopy. I won't say because the exploration in laparoscopy, it won't be the same like open for sure. I'm more comfortable to do this one open, especially repairing full thickness muscle layers. Laparoscopic is not easy.
No, I mean,
So you'll have gas leak, you'll have lots of issues during laparoscopy with such a big defect.
Haider, if you go laparoscopic, how would you repair this? Mesh or primary?
Laparoscopy is not for the repair. Laparoscopy is to have a look to the abdomen, then for repair to open it up.
Okay, so
look, there is no right and wrong. As far as the patient is safe and you follow the ABCD of trauma, I don't think there is any wrong or right. As thing you can back up yourself. If the patient is completely stable and you go with laparoscope and you don't find anything in the bowel, everything is fine, and you just reduce it and repair the wound from outside, I won't say it's wrong.
Yeah, I think the role of laparoscopy in trauma depends very much on an honest assessment of the surgeon's laparoscopic abilities. And if you can safely, truly examine all of the intra-abdominal contents, meaning you can run all of the bowel without ripping it, and you can actually rule out an injury, then there's certainly some role for laparoscopy in some of these repairs. But most trauma really should be open because the risk of missing injuries can be so profound.
I agree with that, yeah.
So a question to all of you: does your protocols or way of management of patient change in the COVID time, or regarding the trauma, it's still the same?
I think in general, what's right for the patient is right for the patient, whether it's COVID time or not. So the things that sometimes change is maybe our use of PPE and those things to protect ourselves. But a patient who belongs in the OT and non-COVID time belongs in the OT and COVID time. Now that said, there's damage control done for the patient condition and there's damage control done for the hospital condition, meaning a mass casualty kind of scenario or the need to save resources. We do have to be mindful of resources, but not operating on a trauma patient who needs an operation just because it's COVID time, in my mind, is medical malpractice.
So either we did not change our practice. Management is still the same. The only difference is we take more precautions to protect the staff. But the patient has not been affected in any way. The same management you get pre-COVID, after COVID, during COVID, it's always the same. It's just it takes us longer to do the PPEs. It's a bit more expensive for us, but it's exactly the same. As a patient, nothing has changed. Just extra precautions to protect our staff.
A question to Dr. Jimmy. If you have a solid organ injury, a spleen, a grade 3, and the hospital that doesn't have an interventional radiology, and the patients have a blood group of B negative, and you know it's very limited sometimes to have a B negative blood. The patient is blood pressure fluctuating, sometimes stable, sometimes tachycardia. Would you refer them for a center, or you prefer to go in?
I would put that spleen in a bucket.
Okay.
I think in general, the patients can live without a spleen, and incisions heal side to side, not end to end. So the patient with a known splenic injury and I don't have the ability to manage non-operatively appropriately, I take out that spleen.
Okay. So I'm missing for the pediatric trauma. Do you take it, or is for pediatric surgery?
No, it's managed by pediatric surgery. So we go up to 12 years. After 12, it's managed by us, by the trauma surgeons. Below 12 is managed by the pediatric surgeons.
Very good.
Nice.
That's our protocol at SSMC.
Okay. So thank you very much, Dr. Salam and your team. It was really delightful. We hope to see you next week on coming Thursday, 9 p.m. We have an update on ventral hernia. Hope everyone can make it. Dr. Salam, thank you again for your cooperation. It's always lovely to see you. Hopefully we can join another meeting in the near future. I'll leave the mic to you.
Thank you, Dr. Salam, for you and for your team. It was an excellent presentation and very beneficial. Thank you again.
Thank you for the invitation.
Thank you very much.
Thank you so much.
Yeah.
Thank you. Bye.
Bye-bye.
So,